Good afternoon, everybody. My name is Garrett Schmidt. I am the managing editor for BBC Exhibit Hall, and I'd like to welcome you all to today's live webinar hosted by CarePort, which is powered by WellSky. And it is titled The 5 Levers of Value-Based Care, Achieving Success Across the Continuum. And I'm really excited about today's presentation. I think there's going to be a lot of great things discussed. But a few items of note before we get started. Everyone has joined today in listen-only mode, so you don't need to worry about muting your microphone or your camera or anything. That's been done for you. Secondly, during the webinar, we are going to have a Q&A time, and we want to hear from you. So please ask your questions. You should have a control module as an attendee where you can actually ask your questions there. So please submit some questions for us if you have anything you're wondering about. And you don't have to wait until the Q&A to do that. You can go ahead and submit those at any time. And Kayla Allen, who's also with CarePort, is going to be helping us out with that Q&A. And then finally, today's session is being recorded. So if you have to drop early or if someone wasn't able to make it at all, I'm going to send out a recording to everybody, a link to the recording, and also where you can get the slides. And so I'll be sending that out probably later on this afternoon after it processes. And that way you can rewatch it, share it with colleagues, and we hope that you do. And so I'll be sending that out later. So finally, without further ado, I wanted to introduce our speaker today, Michael E. Peckgen, who is the head of clinical solutions, and solutions architect at CarePort. Mike has extensive experience in nursing, case management, and managing value-based care initiatives. He received his Bachelor of Science in Nursing at Pennsylvania State University and an MBA in healthcare management at Western Governors University. Mike was first introduced to the CarePort solutions during his time as the Director of Transitional Care Management at Holyoke Medical Center, and which is a subsidiary of Valley Health System, and where he oversaw the health system's care coordination department. So very well experienced. And at this time, I'm going to hand it over to you, Mike. So welcome.
Great, thanks so much, Garrett, and I appreciate everybody coming today and coming to listen to what we can do to optimize your care coordination opportunities within your health systems around value-based care. So just a little background about CarePort for those of you that don't know us. CarePort is powered by WellSky, provides a leading care coordination network in connecting thousands of providers across the United States. We are the end-to-end platform that bridges acute, post-acute, and community-based providers, enhancing visibility into the entire patient journey for both providers, physicians, payers, and all risk-bearing organizations. Healthcare professionals use CarePort to efficiently and effectively coordinate patient care and to better manage patients as they move throughout the continuum. And really, this leads to streamlined care transitions and improved outcomes for both patients and our organizations. Just a quick overview of our solution suite. We're not just a care coordination or tracking tool. We have a suite of solutions that help you throughout your organization better manage and track these patients to optimize their care. Our CarePort care management solution is an EHR agnostic cloud-based solution that is embedded into the care management workflow, helps with that. It does the electronic referrals out to your post-acute care providers and community-based organizations, or what we call CBOs. We have our referral management platform. Think of that as our catcher's mitt to those electronic referrals, and is also kind of like that referral hub for our post-acute care providers or ambulatory centers. Then we have the CarePort Guide tool, and that is allows your care coordinators to help patients choose those high-quality providers and making sure they're getting into the right facility and that's providing that high-quality care. Our Connect tool, I always like to refer to that as our patient tracking tool, or GPS for patients. You want to know where your patients are, the ones that you care about, when they get there, when they leave, and what happened in those organizations or those care centers or locations of care when they got there. Our Insight tool allows you to evaluate patient outcomes and post-acute provider performance with benchmarking and performance data, so you can help choose those networks and where you're trying to get your case managers to send those patients when, again, identifying those high-quality providers to optimize your value-based care programs. And then we have the CarePort Transition product, which is one of a handful of solutions that are embedded in the Epic App Orchard that puts the care coordination technology or the CarePort solutions right into the native workflow of your end users in your native EMR. So pretty exciting. We have all those solutions there. Where I want to start is I want to talk about, kind of today's healthcare system is adapting and evolving, through over the past few years, in the pandemic. COVID-19 has really changed the landscape forever for us. I mean, we've seen a shift to more home-based care, SNF at home, hospital at home, and so forth. But we've been dealing with staffing shortages and harder to place patients. We've had additional administrative burden due to manual workflows, lack of technology to support clinical decision making. We've had to adapt to changing regulations amidst all of these other things. And ultimately, we've seen really just some unsatisfied patients and additional revenue loss. Health systems that have never lost revenue before are losing revenue now. And we really need to kind of stop the hemorrhaging. We need to improve what's going on. What we're looking at here, this is what our continuum looks like today. I don't think you need me to tell you that, but it's just this big web of locations and providers and EHRs, and everybody has their own care coordination team. I mean, what that results in is disparate data. We've got care coordination silos. Every vendor has a strategy for interoperability, but unfortunately, I'll be honest, not all vendors always like to play nice in the sandbox. So, HIEs kind of came into play. We have hospitals using some health information exchanges to extrapolate data and to help their care coordination teams identify those critical points in transition. But that even tends to be a little bit labor intensive at times for end users, especially if they don't have a strong or sophisticated UI to support those workflows. And so what you need is a vendor agnostic solution with a simplified AI, which is really going to allow us and you to transform the future for your organization and the future of your value-based care programs. So technology is only as good as the network or the data that is behind it. So I'd love for you to imagine a world where communication with post-acute providers is seamless, or imagine a world where where you have the visibility into patient care across the continuum. Or even a world where referrals and authorizations are processed electronically, regardless of where you're sending them. But what if I told you that this world is a possibility? Because it is. With the right technology and the application of the 5 levers of value-based care, you can be just as successful in your programs, in your organization, as other clients and organizations across the country that are already leveraging the CarePort technology to help them optimize these programs and optimize their workflows for their end users. But let's first take a look at how value-based care has evolved. I mean, back in 2012, we saw, the implementation of the HRP program. I mean, hospital readmissions were going crazy, costs were soaring for Medicare. So they wanted to step in and do something to control costs. We had, MSSP and ACO started to begin. We saw the launch of the CJR model in 2016. Next-Gen ACO came out. And I mean, we've moved through MSSPs, BPCI Advanced, and so forth, changes to the ACO model. And coming up in 23, the next ACO REACH model, which is essentially a replacement for direct contracting. Moving into 2023. So lots of movement in value-based care. So this is really, the beginning of a new world for us. It's this evolution sparks the beginning of a new era for care coordination, especially as we prepare for a heavier focus on social determinants of health, which is outlined in the ACO REACH. We need to identify the patients that are important to us when they are having these critical transitions. We need to harness that data, and then we need to be able to integrate that into the workflows of the teams that we've established within our organizations to ensure that they're able to engage with those patients. I mean, this is where we're going to be able to provide better treatment, get better access to care for patients, and just provide ultimately a more personalized experience for the patients that we're trying to manage. Technology is a key driver behind achieving true value-based care. It has the power to break down the care coordination silos and other silos within healthcare organizations, connect provider workflows. We want to, it's going to help increase efficiencies and share insights into the overall patient journey. Providers' experience should, increase communication, have an enhanced transparency, and just general better alignment on key metrics with others across the care continuum, the stakeholders across the care continuum. All of this is going to help to transform healthcare delivery and ultimately reward the stakeholders based on outcomes versus quantity. Looking at the first lever, reducing ED utilization. 1 in 5 Americans visit the ED at least once a year, but approximately 2/3 of those visits are avoidable. This is causing unnecessary costs, and when you're involved in a VBC organization, program, that's hitting your bottom line because those patients are presenting and increasing that total cost of care. So ideally, we need to prevent those patients coming in the first place. So why do so many of these patients come back to the ED? These reasons, are pretty important. I mean, they have what we found through our data analysis across the country with the clients that, work with us, lack of timely follow-up care. I mean, you and I both know we've got medication errors or med compliance issues. Sometimes we fail to, I was a case manager, we sometimes fail to identify the appropriate post-acute care needs, even though we did the best that we could. We don't always have 100% complete visibility into the home setting. We only know what the patients and families want to tell us. I think many of you know that. We've had, connection to lack of support in the community, which leads to sometimes inadequate nutrition, transportation issues. And then we also do have the causes that we can't really prevent, post-operative infections and things like that, that unfortunately, we'll have to bring them back in. But preventing patients from being readmitted to the, is the most important thing. And so some of the things that we have seen that have truly impacted that first lever of being successful in value-based care is clients and organizations who have implemented, strong transitional care management programs. Now, I'm not talking about the programs that are just transitions of care, of how you're moving patients from the acute into the post-acute, and then how maybe you work with your post-acutes out into the community. I'm talking about setting up critical points and transitions, getting those patients in for follow-up with your PCP. We know patients that follow up with their primary care providers in that first 24 to 48 hours are extremely successful in keeping those patients from coming back into the ER because they're able to capture those transition failures earlier before they become a problem, which causes that patient to come back to the ED. Also, those organizations who have visibility into when patients are discharged or where they're discharged to, ensuring that patients that are transitioning through the different levels are getting those PCP follow-ups, and then ultimately implementing and managing programs that are supporting the patients long-term. I mean, you have a roster of patients in your ACO, maybe your ACO roster 70,000 patients, or your value-based care program is 70,000 patients. Knowing who those patients are to ensure that patients are receiving the right care at the right time in the right place is absolutely critical. You're not going to actively manage 70,000 patients. Your actively managed patient population is going to dynamically change based on what's occurring with that patient at that point in time. So it's absolutely critical you're using technology such as CarePort or a variant thereof that is going to identify those patients dynamically and notify the teams that are monitoring those patients that, hey, this is time for you to intervene. So thinking to our next lever, which is reducing hospital admissions, the average total cost of care for admissions for an observation stay is about $8,100. We have about $2,600 per day charge and the total cost of care for a hospital inpatient stay nearly approaches $23,000, if not more. When we think about observation and inpatient for a minute, it is at times can be inappropriately used. So when we think about the shift that COVID-19 has really pushed us to, moving care into the home, SNF at home models, hospital at home models, it's really driven by some of the outcome data that we've seen. I mean, and actually the American Journal of Accountable Care recently put out an article, talks about how home health care is tremendously beneficial alternative to hospitalization for millions of Medicare beneficiaries across the country, right? And what they found was that patients who were treated in the home setting were significantly less likely to be admitted or readmitted to the hospital. It's not just about saving revenue, but it's about reducing their hospital admissions, which is leading to just overall better outcomes for your patients, which is ultimately going to reduce your total cost of care, which will drive your value-based program. This leads to question why so many patients are unnecessarily placed in observation, and then why is reducing observation stays important, right? So when we think about the financial impact, I mean, we're looking at about a third less reimbursement on observation stay. You have your clinical impact, which is, patients, especially during the pandemic, we needed the bed space. And then you have patients that are taking up that valuable bed space. We have a lack of resources, so stressing your internal infrastructure. And then overall patient impact, Medicare is not reimbursing for SNF stays that, don't have that qualified 3-day stay. I know we had the waiver in during the pandemic itself for SNFs, but unfortunately that is now, once the waiver has stopped, I mean, in the event that these observation stays are still occurring, the heightened volume of them, that's definitely going to impact if those patients are going out to SNF, whether they're appropriate or inappropriate. There's going to be that higher percentage of the cost that's going to be shifted over to the patient. So it's really patient satisfaction is going to be a factor there. Reducing ob stays and admissions from the ED it's important for all hospitals and health systems, not just those in value-based care. It's absolutely critical to operations. Now, why are some of those patients being placed in observation? I mean, a lot of the data and the research that we've done and through the clients that we spoke to across the country, I mean, it's pretty similar. I mean, I remember my days running in the ED case management program, patients were coming in. It wasn't until we actually put case managers, social workers, and staff them in the emergency room 24 hours a day that doctors had the resources to actually work with these patients and get them out to an alternate level. I mean, but we were seeing a lot of issues around patients, non-medical, or what we call social determinants of health, food, housing, substance abuse, mental health resources. But those things right now tend to be where patients are relying to get help and get tied into those resources. And unfortunately, not every hospital has the resources, the ability to get those patients tied in. And it's also complicated when you don't have technology to assist you. Technology today is going to connect patients with all those local CBOs and can provide the ability to do this more efficiently and effectively in these other types of settings like the emergency room, where historically some of this type of work hasn't been done before. But in order to be successful in value-based care, we have to be able to do those connections in those types of settings to keep those patients from getting those inpatient observation stays inappropriately. So thinking forward to our third lever, unfortunately, there are going to be patients that kind of, we weren't able to keep them out of the hospital. We weren't able to get them out of the emergency room. So now they've gone into the hospital. So now, how are we going to optimize where that patient goes? Are they going to go home? Are they going to go home with home health? Are they going to go home? Are they going to go to a SNF? Are they going to go to an LTAC, IRF? So we really have to identify the next site of post-acute care. So the MPAC came out with a stat that reports that on average, SNF episode is about 2.5 times more expensive than a home health episode. So, and that's going to be the majority, about 33% of your spend on in an episode for one of your value-based care patients, and that might even be an underestimate. But costs vary greatly depending on the setting and the level of care. So identifying the appropriate level of post-acute care for your patient, you potentially could reduce your spend by about 14%. Technology is a critical driver in creating standardized practices, utilizing patient acuity, medical complexity, and to power those post-discharge decisions. I mean, up until recently, case managers worked on a paper list. We listened to the patient, we talked to the family about resources, and we made recommendations based on the needs of that patient. But care has evolved. Services, resources, and availability of those things have evolved in the community, which now allows us to consider alternative locations for patients that could potentially save cost at the end of the day for our value-based organizations. So, where does your organization fall? I mean, we've seen organizations that go quite left and quite right. They're kind of all over the board. We see some that have high levels of discharges to home health agencies, some with very high level to SNF. So where do you fall? Do you know where you measure up against your peers? And do you know how your organization makes level of care decisions today? And are you confident you're discharging patients to the right level of care? We have organizations that have come to us and said, I know that we overutilize SNF level of care. How can you help us solve that? CarePort can provide predictive analytics to help guide and validate your clinical decision making. CarePort provides a level of care indicator, to help with our vast network of national providers. And in reality, our data is unmatched. The one advantage to using a partner such as CarePort with a national network of providers is that the data used to drive our predictive analytics models versus a siloed data set like your native EMR. I mean, most of our EMRs have risk-based scoring, but it's a very siloed data set. Our data's being cross-referenced with data sets across a national network, whereas EMR vendors, it's very much siloed. So we're giving you a much broader perspective of where we think your patient belongs or what level of care they need post-discharge because we have access to a vast array of data nationally. So now that we have projected where we think your patients should go based on how medically complex they are and the risk of returning to the hospital based on the your next site of care, we need to optimize your SNF length of stay. So in the US, the average monthly cost for a skilled nursing ranges from about $7,600 to about $8,700. With CarePort, we have seen that for a relatively efficient post-acute stay or SNF stay, we've achieved an average length of stay of about 27 days. But with CarePort, we think we can improve this. Looking at your post-acute facilities, building a census of who your patients are and when they arrived and what's going on with them in that facility is absolutely critical to understanding how long we think that patient should be there and what's their care plan and so forth. What CarePort does is we're receiving that data in real time, and then we're projecting an estimated post-acute length of stay for that facility. And then our platform allows you then to set a target discharge date, which allows you to work collaboratively with your post-acute care providers in hitting that target discharge date. We can talk about some of the results where the SNF length of stay was optimized using CarePort technology and as we look forward. We had for an ACO, we've improved performance where they were situated in the 4th quartile when compared to other ACOs in the US, and we moved them to the 1st quartile. We were able to successfully reduce that post-acute length of stay by 1/3, which was about 9 days for that organization using our models, which ultimately resulted in about a $1,500 savings per patient. And then our final lever is hospital readmissions. Roughly 2 million patients are readmitted to the hospital annually. We cost Medicare about $26 million. It's estimated about 17 billion that is caused by potentially caused by potentially avoidable readmissions. So when we think about potentially avoidable, it's all the things that we may or may not have done in those critical points in transition, right? We didn't get that home health set up, or maybe home health didn't start in time, and so forth. And then also maybe a lack of post-acute follow-up. So, we are, as hospitals are under increasing pressure to reduce those avoidable hospital readmissions, we need to come up with some strategies to do that. And what we've seen successful and what we've implemented, with our clients across the US are those strong transitional care management programs. So when patients are moving from hospital to home, or hospital to SNF, or SNF back to community, those programs are in place to identify those critical points in transition, so they get that appropriate follow-up, they get those MedRecs completed, they understand their discharge instructions, and it makes them more successful in keeping them from coming back in and failing in that transition. We also are enabling ambulatory navigators who get patients connected to the community, community-based resources using patient-level referrals and getting those referrals out to food banks or other community-based orgs who are processing or referrals electronically. We're helping guide clients to high-performing providers during that discharge process. We're using real-time updates when patients are admitting and discharging from those levels of care, because that's when you have to engage with those patients or make sure that you're working with those levels of care to support those transitions. And then identify gaps in those care opportunities for improvement with the post-acute care network. And then drill down to evaluate the post-acute provider performance, specifically those that are tied to episodic-based, value-based initiatives. So think about like your BPCI initiatives. You need to have a way to identify when that episode starts, when that episode ends. Some of the inherent challenges around that is organizations don't have the dynamic and automated ability to do that. So there's a lot of end user manipulation in the record to identify who is that patient going to be, or you have to review the chart, you click the flag, and 90 days ended, now I'm going to go in and I'm going to unclick that flag, or you end the episode. You need technology that is going to be able to do that automatically for you. We need to decrease the burden on the limited resources that we do have, the ones that are already taxed. We need to make them more efficient and allow them to spend their time focusing on working with the patient and not trying to manually flag and unflag patients into these different risk-based programs. One of the things I just wanted to share is that we ran some data and looking at providers who use technology to facilitate and optimize care coordination initiatives. We see significantly higher performance around readmissions, post-acute length of stay optimization, and so forth. So when we look at that, let's go back one slide. When we looked at this data over Q1, this is a spread of number of patients that were discharged associated with ambulatory providers who use our technology to identify their patients. So we think about primary care physicians and practices. And what we found were that patients that were discharged, that were associated with these providers, that use CarePort technology to identify that their patients were transitioning, they performed 14% better on 30-day readmission rates than providers that did not. That accrued in their value-based programs about $460,000 in savings in prevented readmissions. So pretty significant impact overall in that total cost of care for those providers. So with that, I think we're going to go to some questions.
We're going to do some questions. Hi, everyone. Okay, Mike, so I have a good question for you. This is, what are the two top reasons, medical conditions for which SNF patients are readmitted to the hospital, and how does CarePort address them to mitigate those readmissions?
I'm sorry, can you repeat that one more time?
What are the top 2 reasons for which SNF patients are readmitted to the hospital? And how do we address those readmissions?
That is a good question.
You just name some of the top ones. It doesn't have to be the top 2.
Yeah, so some of the top reasons patients are coming back. We have patients that have post-operative infections, IV antibiotics. They also have complications with let's see here. I think they have some complications with like Foley catheters and so forth. They don't have the resources internally all the time, especially in post-pandemic, to be able to deal with these things. So they're being sent back to the hospital. And unfortunately, once they get to the hospital, we're not able to get them back out.
All right, so I have another question that's come in. How do you support, how does CarePort support new clients, or I guess this is specific to your team as well, but how does your CarePort support new clients in developing their own VBC or value-based care programs?
Yeah, that's a great question. So at CarePort, we take a very prescriptive approach to implementation. When you decide to partner with CarePort, you're not only partnering with our technology, but you're partnering with industry experts. So specifically, we have our implementation team. We have clinical specialists who have lived and breathed care coordination. Most of them have run care coordination departments and value-based programs themselves. And they will come in and work with the implementation and your teams to come up to identify how you work with patients today, how your programs are designed and operationalized, and then how can we overlay our technology to support those initiatives versus rip and replace. And then long-term, once that implementation is done, you are assigned a dedicated account team where you have a client success manager, as well as a client relationship executive who is normally a clinician or a very well-versed in healthcare operations, someone that's very well-versed in healthcare operations.
Okay, thank you. I just want to, a quick reminder for everyone too, that you can ask questions. Just type it in the question box and we'll get those. Thanks for everyone who has so far. So we have another question for you, Mike. So someone says, we're starting to think about incorporating more home-based care programs into our network. How does CarePort support those?
Yeah, it's another great question. We've implemented quite a few home-based programs across the country, actually. And we take feeds not only from the acute hospitals, but we have SNF feeds, LTAC feeds, home health feeds, hospice feeds, and behavioral health feeds, and all of that comes into our application. And then we've created custom integrations with some of our EMRs for organizations who are running their own programs to identify new levels of care that will allow the care teams to identify who those patients are, so that if they happen to show up back in the emergency room or things like that, they know that this patient is a hospital at home patient right away. But we have multiple workflows and ways to identify those patients in real time based on multiple feeds from our entire national network.
Okay. We have another question that's coming in. What are some of CarePort's KPIs for measuring the effectiveness of the program, the value-based care program? How does CarePort track their solution?
Yeah, so we do it in multiple ways. So we work collaboratively with the client to identify there's certain data elements that CarePort does not have access to. But we can work with the client to overlay some of our data to define KPIs that are specific to the workflow or implementation that we did for that particular client. So thinking specifically for a client that I was working, a large integrated delivery and financing system, we utilized a mix of claims data that was provided by the client in conjunction with our utilization data from the application, and we were able to identify through our application who the attributed patient populations were tied to specific groups across their network. And we were able to isolate user access and different searches and things that they would do during their workflow. And we were able to show that through the utilization of the system, the claims that were populating during that specific time frame, how successful that particular workflow or that implementation was. So I don't want to say there's specific things. I like to say that the account team that I put in to work with you both during your implementation and after the implementation, they sit down and work with you to define your metrics for success, and then we figure out how to work with you to call those out and then review them on a regular basis with you.
Okay, great answer, thank you. Let's see, how does CarePort predict the SNF expected length of stay?
That's a great question. So at a super high level, we create clinical profiles of every patient that comes into our system, and age, sex, gender, clinical complexity. We use ICD-10 codes that we receive from all of our post-acutes and our acute providers. We create that clinical profile, and then we measure how well a patient of similar clinical profile performed at a specific level of care with a specific quality in prior instances. And then based on that, how likely, and then we use a risk-adjusted model to determine how long we think that patient actually needs to be there to be successfully discharged back to the community without likelihood of readmission. So it's a pretty complex algorithm that runs through our data science team who designed that. And actually in the one results slide that I went over regarding that ACO, they utilized that model utilizing our ELOS and was able to shift that by 9 days. So pretty sophisticated, but successful and accurate. We do know there's more models out there that are a lot more aggressive. However, it may not always be in the best interest of that patient to be that aggressive. So we like to be more realistic.
Another question came in, and is the CarePort length of stay, I think she means expected length of stay model, the same metric as CMS GMLS?
No, it is not. It is not. We use our own risk-adjusted algorithm that was developed by our data science team as proprietary to CarePort.
Okay. So we have another question here. Thanks everyone for asking questions. These are great. Just keep them coming in. Let's see. So this person says that they already get a lot of data from an HIE. So why do they need CarePort? What's different?
So while HIEs are valuable sources of patient data, the HIE data is typically only a supplement to the value that CarePort can provide. CarePort's more than just a data source, right? Instead, the CarePort platform ingests that HIE data and makes it actionable for your organization. CarePort covers a national network, including all of your post-acute care providers, an area where HIEs are typically weaker. So what kinds of insights and reporting does it currently offer? And additionally, does your HIE provide any sort of workflow tools for your users? How reliable is its patient matching capabilities? When you think about CarePort, we're a total solution. It's a complete platform to manage the entire transition of care beyond. While the HIE is a valuable data source, many of our customers rely on both. And CarePort has data sharing agreements with multiple HIEs across the US today. So it is not unheard of that a client that is currently ingesting HIE data needs CarePort to help them make it more actionable and user-friendly. HIEs are strong in data. They're not strong in user workflow. Okay. And that's where we specialize.
Another question we have. We touched on this briefly, but I don't know if we talked too much about it in this presentation, but in CarePort Guide, we have the CarePort Quality Score. So what is the difference between the CarePort Quality Score and the CMS Quality Score?
Great question. So the CMS Quality Score is updated on a regular cadence, 2-3 times a year. Whenever things occur, they also have, the citation alerts and things like that. With the CarePort Quality Score, we are updating that in real time. And we're also basing our quality score only off of short stay measures, where in the CMS Quality Score, long stay measures are included in that. So when our data science team looked at all the data models and we looked at performance of post-acute care facilities, and when we were developing our quality score rating, we determined that we needed a better way to identify quality than what CMS was delivering through their CMS score. So we isolated the what we felt the quality indicators were in the short stay measures, and we adjust our score in real time. So we're giving you a more realistic, real-time view of the quality of care that those facilities are providing versus more aged data and not necessarily applicable to all short stay patients, because they're including long-term patients as well in their CMS rating. So it's we believe a better quality score.
Awesome. Another question here is why are patients, so we're seeing that patients are being discharged to home health more than SNFs. What's the reason for that? And is there, how do they deal with the pricing difference of that?
So, with COVID, we had that big shift to home. And I think earlier in the presentation, I talked a little bit about the cost. I think we were saying the SNF stay is about 2.5 times more expensive than going to SNF. And then also the shift is also driven by a lack of resources on the post-acute side. Just as much as hospitals are struggling with staffing and resource availability, SNFs are also struggling with the same. They're having the same staffing issues as well. So I think it's a combined factor of more patients wanting to stay home, receive the care in the home where they feel comfortable, which has also been proven to deliver better outcomes than actually when care is being received in a facility. So
right, we saw that in the American Journal publication, that patients recover better at home than in the acute setting. Yeah. Let's see. I think we have one more question. This may be good for you. So when you're implementing a CarePort, what are some of the biggest challenges you face and how have you overcome those?
Yeah, so I think probably one of the biggest challenges that we have is when organizations see the inherent value of everything that I just spoke about, breaking down silos, increasing communication and transparency across different settings of care. One of probably the biggest challenges that we see are when we're brought into an organization who is just kind of like groundbreaking in moving into that value-based space. They haven't really developed the relationships yet with their post-acute care providers. They don't really have any of those points of contacts and so forth. And I think that's probably always the biggest challenge because, when we're moving into one of those markets where it's kind of like net new, maybe there's we call it just green space, especially I think that becomes one of the greatest challenges because you're opening up lines of communication or discussions that you've never had before with those providers. But when CarePort comes in, we work with you to kind of outline that messaging. We have teams that specialize in working with those providers, and we can share suggestions and different models with you that we have explored and experienced across the country with other clients that have made them successful and help grow and foster those relationships with those post-acute providers. So it's consulting, it's a consultative, prescriptive approach to engaging those relationships, and also working with you to craft the correct messaging around getting those any missing data connections that we don't currently have today.
Another good question that I think you'll like to answer is, do we use AI to predict the next level of care, either home health versus skilled nursing?
So we have an intelligent predictive analytics model. It is what we would consider CarePort's AI. And I think AI is a very broadly used term by many companies in the technology industry. So I would say that, is it machine learning? Not 100%, but it is a model that definitely evolves over time and gets stronger and better the more data that we are processing through our engines.
And I think that's the point to make or to note there is that our network of providers is so large, so our data set is unmatched and unparalleled. So we have access to a nationwide set of data for patients, so we're able to predict that next level of care.
Absolutely, Kevin.
We had a great question. So this person's utilizing CarePort Connect and Insight. And they asked if they say Insight's the most exciting solution to see real-time length of stay and readmission rates. And she turned in late and she wanted to know if we focused on this in the presentation, and we did touch on this, but if you wanted to touch on that a little bit more, that would be great.
Yeah, so I think I talked about it a little bit. Yes, Insight is our post-acute analytics tool. What I love about Insight is that we can isolate down to the cohorts and the patient populations that are appropriate to you guys, when you need to know about those patients, whether you're in BPCI, ACOs, whether you're in risk-based arrangements with your commercial payers, we can isolate those patients and then we can measure the performance of those individual patient cohorts, looking at both CMS-based data, we can benchmark, and we're able to allow you to essentially scorecard against all of the other post-acute providers in that network, and allows you to identify in real time which providers you really want to partner with, where do you really want to send your patients, and which providers are actually performing or providing optimal care to your patients. So it's a little bit more in depth in that regard, but yes, length of stay, rehospitalizations, CMS ratings, CarePort quality scores all incorporated in real time in our Insight dashboards.
All right, guys, we have time for just a few more questions. See if anything comes in. But Mike, thank you for speaking with us today. Thanks for presenting. I think Garrett may still be on the line. I know he wanted to touch on our booth. Yes, here, Garrett.
Hey guys, yeah, thank you, and what a great presentation. There was obviously a lot here, and so we realized that you'll probably want to go back over the presentation and the slides, and so what I'm going to do is just to let you know, I'm going to send everyone who registered a link to the recording, as well as a place where you can download your slides. And to Kayla's point, and by the way, Mike, great presentation. This was wonderful. I really got a lot out of it too. I hope everyone else on the line did as well. But as we conclude here, as Kayla mentioned, I wanted to encourage you all to visit the CarePort booth. It's a virtual interactive booth on bbcexhibithall.com. You're seeing it here on your slide. And there, if you go there, it's kind of a snapshot sort of what they're doing in this space. And so you can kind of get some highlights of what they're doing and interact with their team. And there's a lot of resources there for you. So definitely encourage you to check that out. And then lastly, if you would like to contact the CarePort team or Mike or Kayla, please feel free to reach out on this slide. You can see their email address there, or you can reach out to me and I'm happy to facilitate an introduction for you. But wanted to thank you all so much for your time today, for joining us. I know there's a lot vying for your attention right now this time of year, but I hope you found today's presentation informative and helpful. And I want to extend a special thank you to all of you out there for doing what you do to improve value-based care in America. And I know that CarePort is a big part of that too. So thank you all, and hope you have a wonderful rest of your days. Bye-bye now.
Thank you, everyone.
Thank you.